Welcome to the regular meeting of the Boulder County Board of Health. The date is Monday, November 14th, 2022. And we are meeting and still in a hybrid fashion per our bylaws. Board members are here, some staff are here, and the rest of the folks are online. So we have first on the agenda, public comment. I believe we have 4 people signed up to give public comment. Jordan?
Yep. So the first one that we have that the people that are online would be Carolyn Beninsky. So Carolyn, I'm going to make you a presenter and then you should be able to unmute and you will have 3 minutes.
Hello, can you hear me?
Yes, they can.
Okay, I'm Carolyn Beninsky and I'm here representing No Vax Mandates Colorado. In the last several months, BCPH held focus groups to convince vaccine hesitant parents of small children, particularly Latinos, to inject their children with the COVID shot. The public heard about these focus groups from Indira at the June Board of Health meeting. At the next BOH meeting, I emphasized that the experimental designation of the COVID shot required you to present both the benefits and risks to parents. This information is required both by the Nuremberg Code and by federal law. The public has informed the board on repeated occasions about the adverse effects of the shots, including pericarditis and myocarditis in children. These risks are listed on the manufacturer's inserts. No Vax Mandates sent both the board and the executive director a 6-page document outlining the dangers and lack of necessity of the shots for children. The shots do not stop infection or transmission according to the CDC, and therefore they are not vaccines. It is very clear that the risks of these shots for children far outweigh the benefits. The focus groups were not brought up except briefly at subsequent BOH meetings. In a September 12th email from Ms. Nolan, we were told that the focus groups were over and that the information gained is helping us, this is what she said, in our public communications to answer questions and address misinformation. The statement was very concerning to us given the known risks of the vaccine. No Vaccine Colorado sent an email on September 26th with several questions to the board and to Lexi Nolan about the focus groups. We have received no answers. We filed a Cora request on October 31st with our specific questions, and we're told it would take 25 hours and would cost $720. On November 8th, we filed another Cora request and requested only 3 existing documents, which were the focus group summary report, 2, the invoice for expenses if BCH used a consulting firm, and 3, expense report of the project. We were told it would take 10 hours and $270 to obtain these documents.
30 seconds.
Well, it has become clear to us that the BCPH does not want the public to know what happened in the focus groups and how much it costs. It appears that BCPH is actively trying to discourage us from obtaining these documents that would take 1 hour to retrieve and send to us. This stonewalling is in violation of Cora and violates state law, and we ask you to intervene and to ask BCPH to send us the documents, 3
That's
existing
fine.
documents.
Okay, and next we have Ryan Scott. So Ryan, I'm going to make you a presenter and you should be able to unmute.
Great, thank you. Can you hear me?
Yes, you're good.
Super. Thanks much, Caroline, for speaking up. That was great. I always admire those folks in the community that are speaking out. As of this week, just as a recap, the Vaccine Adverse Reporting System, VAERS, has now logged over 1.4 million adverse events associated with COVID-19 shots. including more than 30,000 deaths, half of which are from the United States. No other vaccine has ever caused this many injuries. For those that tune in or watch this, go to vacsafety.org and also look at Children's Health Defense to gain a different perspective than what BCPH and CDPHE is pushing. As of this week, there's a billboard outside the CDC headquarters in Atlanta that reads, "How many more kids have to die before the CDC stops the COVID shot?" And there's another one that reads, "The death safety signal in VARS was triggered a long time ago. Why didn't anyone at the CDC notice?" And this is with their own calculations from their own data. Clearly not many eyes on vaccine safety, and clearly zero harms that you could ever acknowledge from vaccines, which is really, really unfortunate. While the harms are undeniable, health authorities are still doing what they can to deny the risks associated with COVID shots. U.S. Center for Disease Control and Prevention fought for 15 months to avoid releasing VSafe data. This would just be making data transparent to everyone. Seems a bit shady, like ongoing things. FDA and CDC approvals based on reading self-reports from pharmaceutical companies about the impact of a vaccine on a single proxy, antibodies, that everyone acknowledges is not a correlate of protection. Thus, the stupidity we've gone through with PCR tests and everything related to high cycle thresholds with all the PCR tests and lockdowns and everything that you thrust upon this community. Hence the reason we're speaking out. People are angry. You defied common logic. You vilified certain groups, unvaccinated. You've permanently traumatized folks. I hope you can read that. Those would be the folks driving wearing a mask in their own car. Defies all logic, sanity. These are just traumatized people. Unfortunate. From mass to breakthrough cases to alternative treatments, the so-called experts have amassed a track record of incorrect judgments that make political pollsters look good by comparison. Even in the fog of a once-in-a-century
30
pandemic,
seconds.
these decisions were just born of inexpert and incorrect scientific knowledge, but just rather driven by a rush to push a medical agenda, one that unfortunately you're still propagating. CDPHE is still propagating. Get vaccinated, that'll save the world, that'll save everybody. It's just incessant, it gets tiring, the community is sick of it. And I'm engaging with as many folks as I can around town as a small business owner myself, and will continue to apply pressure on your group. Thanks much.
That's time. And the other two people that signed up are not online, so that concludes public comment.
Okay. That concludes public comment. Moving on to item 2, approval of the October 10th regular meeting minutes.
This is Brooke. I move that we approve the October 10th regular meeting minutes.
Morgan, I will second.
All in favor?
Hello? Can anyone hear me? Hello?
Oh,
Hi, oh, there was one other person for,
Yes, this is Marty Hopper. I am online and I did sign up and I would
Okay.
like to speak.
go ahead, Marty.
Okay, thank you. Should I just go ahead and start then?
Absolutely.
Okay, thank you so much. Okay, so my name's Marty Hopper. I live here in Boulder, and I'm speaking tonight because I have very serious concerns about Boulder County Public Health's continuing promotion of the COVID vaccines for children and infants as young as 6 months old. As we all know, COVID-19 is not a childhood illness. And in fact, national data demonstrate the likelihood of a child surviving COVID is 99.997%. If you go to Boulder County Public Health's website and click on the link called COVID-19 Children and Youth, the very first thing that pops up is the recommended COVID vaccination schedule for each age group by manufacturer, along with information on where to get vaccinated. Where is information on healthy eating, exercise, playing outdoors, vitamin D, and human connection? The only intervention promoted is vaccination. Directly under the schedule is this statement, quote, "The FDA has authorized COVID-19 vaccines for children as young as 6 months old, period," end quote. This statement is not true. The FDA has authorized COVID vaccines for children under emergency use only, yet you have chosen to leave out the words emergency use. that it is an extraordinary omission as well as a violation of informed consent. Scrolling down further on the page is a statement that the COVID vaccines are, quote, safe and effective, unquote. What is your evidence? It turns out that the CDC and FDA's joint vaccine safety reporting system, VAERS, that Ryan mentioned, reports the following as of November 4th. For children 6 months to 17 years old, there have been 59,000 reports of vaccine injuries, including deaths, permanent disabilities, 2,000 cases of myocarditis, and thousands of hospital visits. Are you informing parents of these risks? Also on the children and youth page is the statement, quote, there are no long-term side effects from the vaccine, end quote. The FDA approved COVID vaccines for children as young as 6 months old on June 17th of this year, which is exactly 5 months ago. How can Boulder County Public Health
30
possibly,
seconds.
with any good conscience or ethics, state this as fact when no data can possibly be available in the period of only 5 months? Finally, what has happened to the precautionary principle when it comes to the health and safety of Boulder County residents when infants and children are being induced to receive an experimental injection with emergency use authorization and unknown long-term side effects? I ask you at the very least to revise
That's
your
time.
website. Thank you.
Sorry about that. Sorry, Marty. It was Marty Harper.
All right. That's it. All right. Okay. Thank you. And then item 2, back to item 2. So we had a motion and a second on the approval of the October 10th minutes. All in favor? Aye.
Aye.
Okay, motion passes. Item 3, request Board of Health approval and adoption of proposed Boulder County ordinance 22-8, an ordinance repealing ordinance 2019-01, amending and reenacting these rules governing animal control.
Hey everyone, Kate Haywood with the County Attorney's Office bringing you this agenda item. I have been working with my colleagues in the County Attorney's Office as well as animal control officers in the Boulder County Sheriff's Office to make some updates to the existing Animal Control Ordinance 2019-1 to align the ordinance with some updated laws that were recently passed by the legislature. I did send a summary of the changes to the ordinance to the board. And I guess I should take a step back and clarify, this is a county ordinance that is going to be put before the Board of County Commissioners for its consideration. We are seeking the Board of Health's approval and adoption of this proposed ordinance as well, as there is an order by the Board of Health contained in this ordinance pursuant to the Board of Health's authority specifically to require rabies vaccinations for cats, dogs, and ferrets. So with these changes, the foundation of the ordinance with respect to the Board of Health's role requiring rabies vaccinations, that is not changing. That primary piece is not changing. What is changing is some other aspects of the ordinance. So I'll just touch upon the changes really briefly, and then if anyone has any questions, please let me know. So the primary change that is being incorporated into the ordinance is to permit personnel beyond veterinarians to administer rabies vaccines, so long as the personnel are trained and are indirectly or directly supervised by a veterinarian. So this contemplates, other staff in a vet's office. The vet appropriately trains them and supervises them, whether directly or indirectly, then those other staff would be able to administer the rabies vaccines. This is especially important for humane societies and the like, where, they might have one vet for a lot of animals. Since we're cracking the ordinance open, want to take an opportunity to make some additional changes as well. Pursuant to Senate Bill 21-271, pursuant to the misdemeanor reform effort, the allowable punishments and classifications for a violation of a county ordinance is changed. So we cleaned that up as well to align with the misdemeanor reform bill, updated the schedule of fines, and then added some clarifications that are helpful for enforcement. For example, providing a more precise definition of persistent barking, which has been difficult for law enforcement to enforce in the past without clear definition in place. So that pretty much covers the major changes. Happy to answer any questions about the ordinance, but otherwise, if the board approves and adopts this ordinance, it'll just sort of be passed on to the Board of County Commissioners. In the event they were to request any changes, we would bring the changes back to the board to reapprove. But hopefully, smooth sailing from here. So does anybody have any questions?
Yeah, I have a question, Kate. Under penalties, you have class 2, I think this is just a typo. It has
Oh.
class 2 misdemeanor bodily injury. It has that the max punishment is reduced from 3 months, which would be like 90 something days, like 93 days, to 120 days.
Yeah, let me double check. It might actually be correct, but let me dig in to do some research and I will follow up on whether or not that is a typo.
And then I also had a question. So it looks like even for ferocious dog at large, the maximum penalty is being reduced from 1,000 to 300. Is that a state maximum that's been imposed, and that's so we cannot go over 300?
Absolutely, yes, that is the case. That misdemeanor reform bill reduced the classifications and the corresponding maximum punishments as a part of a whole scale sweep across many Colorado statutes and offenses. So that would be the reason for reduced penalties.
Okay, but those are the state mandated maximums. We're not going below
Correct, the
those.
state,
Okay.
yes, there are state statutes that set the maximum allowable penalties for a violation of a county ordinance.
Thank you.
Kate, with the change to allowing non-vets or to do the rabies vaccines, did that come from like a veterinary state lobby or something, I'm assuming?
Yes, it's my
Okay.
understanding that, there were efforts, I know that it was intended to in part help humane societies that, just aren't able to keep up with the demand with, a single vet on site. But yeah, so there was a push to sort of help them out in that way. Also did run these changes by Public Health's Communicable Disease Division, and they were comfortable with the language as it stands. So want to make sure you're all aware of that as well.
Yeah, I just wanted, so this was like, the industry is anticipating these changes.
Yeah, this was an ask of the industry, and clearly the legislature found it reasonable and implemented it. So just trying to close the loop.
Awesome, thank you.
Yep.
No other questions? Okay, thank you, Kate. Looks like we need to motion to approve.
I don't, do you have the actual, the ordinance number as, oh, okay.
Yeah, we
I
just got the
move-
number
Okay, I move
2022-8.
that we approve ordinance number 2022-8, an ordinance repealing ordinance number 2019-01 and amending and reenacting these rules and regulations governing animal control.
I will second.
Motion in a second, all in favor? Aye.
Aye.
Okay, thank you. Motion is approved.
Thank you.
Thanks, Kate.
Thanks, Kate.
Okay, item 4, policy planning and expectation.
Good evening, Board of Health and guests. I'm Lexi Nolan, Interim Executive Director for Boulder County Public Health. Thanks for considering this item tonight. This is informational and for discussion. BCPH leadership is currently discussing a number of approaches to better support our strategic goals as an agency as part of our strategic planning process, including a stronger investment in supporting pro-health and pro-equity policy, particularly at the state and local levels. Although BCPH has engaged policy work in the past, we do not have dedicated resources nor goals related to our strategic plan. This year, we'd like to explore what it would take to more effectively support this kind of policy work, including in terms of staffing and operational resources, as well as the kinds of goals, work plans, and processes needed. The presentation tonight will review development of pro-health policy as an essential public health service, review and provide examples of how we've engaged policy work in the past, and provide some early ideas of what it might look like going forward. We hope that the presentation creates a space for discussion with board members about prioritizing policy work and our board members' own interests, and sets us up for a fruitful discussion in January with our county partners on priorities for this legislative session. Next slide. So just as a reminder, policy is part of the public health, the 10 essential public health functions. It shows up in a number of ways. It is considered core to public health work, and it really helps public health to not just address problems after the fact, but to really get into the business of primary prevention, addressing root causes, improving systems and processes in a variety of ways. That allow us to better address poverty, racism, gender discrimination, other forms of oppression that result in health inequities. So there's big P policies, public rules, legislation, for example, and small p policies, which relate more to organizational rules and systems. Both are included in this kind of work. Some of the typical activities that public health engages in these spaces are sharing policy relevant data and subject matter expertise with partners and decision makers, mobilizing and supporting aligned messaging with community partners, and monitoring and reporting back on implementation of policies. There's a whole area of implementation science that we like to track, and how well is this policy actually effectively leading to the goals that we are seeking. Just to mention, other LPHAs, other local public health agencies have dedicated positions for policy work. Boulder County Public Health does not at this time. We don't have anyone that can really has protected time to support analysis and coordination of the work. Currently, Lane Drager from our Consumer Protection Program and Heather Crate from our Community Health Division Manager are supporting this work as they're able to find time in addition to their usual work. And they will be presenting this evening on kind of looking back and looking forward.
Can I just ask Lexi about that staffing piece?
Yes.
Do the commissioners, policy folks, team, when they come in and present to us, I mean, are they sort of working in coordination with BCPH? Do they follow BCPH's lead, or do we sort of, how does that relationship go?
We coordinate as much as we have capacity to.
Okay.
And I think Lane will talk a little bit more about that, and he can give you a lot more details about what that looks like.
Great. Thanks.
Yep. All yours, Lane.
All right, thanks. Next slide, please. I'm getting bad reception. I don't know if you can hear me.
Yes, we
There
can.
you go.
Yes.
Okay, it's still on the first slide for me, but the things that we've been doing are things that I think we still envision doing in the future, ideally just, I think, more proactively. So as you just mentioned, Morgan, we've worked very closely with the commissioner's policy team. Typically, from program to program, when there are initiatives that they have, they reach out and talk to the policy team and work with them on our position and share all that insight so that our commissioners team can actively work on our behalf as well. So I think that is work that we have done historically and absolutely see moving forward. So we have a good relationship. I think we have 3 former public health staff as part of the commissioner's policy team. So they're very connected to public health in the staff that they've selected. So public health is pretty essential to a lot of the work that the county as a whole is doing. They also have been convening the Human Services Policy Group. So that is a group where public health has been actively engaged along with our peers at Housing Human Services and Community Services. So we still see that as a critical way for all of us to be well informed from all the angles that these policy issues bring up, so that we are not stumbling down a way and creating unintended consequences for some of our peers, and again can bring that collective voice to those issues. Recently, they've started a climate and.
Oh, sorry, I was just gonna ask a quick question. I can't remember, does BCPH ever act, is it ever proactive in policy? Does the county ever drive policy, or is it purely reactive? So whatever the legislature brings forward?
It's both. So I think the work that our programs have done with the policy team at the commissioner's office has been very much proactive and also somewhat reactive when there's stuff that we potentially don't want to see get passed. So it's been a combination. I think our thoughts though, moving forward, we'd like to see more bandwidth and capacity to do more proactive work, but we have absolutely been engaged in proactive work historically, and see that as still a critical need moving forward. It is one of our essential services, and really that community-based, that community level public health interaction is where we have the potential to make the biggest public health impact to our community. So that setting policy, especially state policy, as well as our local policies. We still would also envision working with other public health officials and the other public health departments. So CALFO is that professional association. They are likely going to continue to have a focus on infrastructure and our sustainable funding. So that's something that is still critical to us as well. As you hear from programs and as you've heard from programs over time, there's really a lack of resources across the board. So that is still a fundamental need. But CALFO only has so much capacity. So again, all these different partners, I think will play key roles, and we'll be continuing to work with many of them. The Colorado Public Health Association also has a policy committee, and they also employ a lobbyist, and they have been very proactive in the public health space, given their sort of limited budget. So I think I would still see us being very active with them and weighing in on their surveys for priorities, as Lexi has already done for CALFO's priorities. So trying to make sure that our voice is heard there. The Denver Metro Partnership has also been a key partnership for those metro health departments. They've put some focus into climate change efforts and other initiatives that we all need to have a collective voice on that impact all of us holistically. CC4CA, all these different groups that Boulder County and Boulder staff have been pretty active in engaging and working with. Still going to be critical partners as we look at climate issues, and a lot more legislation still needed to address some of those issues, and also work on the implementation side, which I know Commissioner's staff and Bill Hayes and his team will still be active in too, because the rulemaking and the processes there are still pretty critical. And other partnerships, Colorado Partnership for Thriving Families. One that I don't think we've engaged with as much is the Consortium of Cities, but I think there's still bandwidth there moving forward as we think of our local policies and the municipalities setting policy along with comprehensive plans, so that we really make sure health and all policies is something that's very actively done. Partnerships, I think, has always been one of the strengths of BCPH programs. We have a long history of working with our community. This was the biggest year ever for recognizing our Healthy Community Awards partners, but it just is a snapshot, as every year is, of all that amazing work that's happening. But another area that I think we really can augment, especially with more concerted effort, is bringing those voices so that they can be heard too, and and well informed and when they are being heard. So, you heard public comment about the VAERS database, and we won't get sidetracked too much on that, but there's huge disclaimers on anyone can report anything. And there's people that have gotten snake bites and gunshots from the vaccine too, because that's what people can write and report, and it all goes into the database. So an informed community is a critical importance too. And I think Heather's got the next slide.
Thank you, Lane. Good evening, Board of Health. I'm going to share a few recent examples of policy engagement. We recently partnered with Metro Denver Partnership for Health to sign on to a letter that was sent to the Colorado Department of Revenue looking at regulating kratom products, kratom processing, and kratom retailers. This was an issue that was brought up in CalFO last. Some potential now moved. Sorry.
I don't actually know what kratom is. What is it?
High potency,
Kratom is
marijuana products, right?
Kratom is the bane of my
Yeah,
existence.
oil.
Oh, high potency marijuana products. Got it. Sorry to be such a square.
Well,
Board of Health members.
Kratom
No,
is complicated.
kratom is oil,
Kratom is
right?
complicated.
Okay.
Kratom also has opiates in it, sometimes at least.
Got it. Okay.
Yeah. So kratom is often sold as kind of a natural herbal additive or for folks to use. One of the main concerns that was an issue is that there's no real regulation of what's in it and what makes it up. And there were some cases in Colorado where it was being added to food as a nutritional supplement, and it caused a lot of health issues for folks. So there's, instead of the legislation going through, there's sort of more of a study happening around kratom and what regulation should look like. So we've been working on that. Our tobacco program manager within public health is pretty well versed on what regulation might look like. Another piece of effort that's more at the local level is our generations and Genesis staff within the community health division testified at City of Boulder and are working at the Boulder County level to reduce, to remove taxation of menstrual products. And that would include baby diapers and adult incontinence products as well. There was legislation that happened at the state level, so we feel pretty good about the county and City of Boulder removing those taxes as well. In this past legislative session at the state level, some of our leadership and OASIS staff worked with Boulder County to coordinate testimony to help pass legislation that will now include gender and sexual orientation on public health data collection, which was a real big win. And then more of a school district or school education level policy. Some of our youth, which is part of that community engagement from Youth Advocating for Change within the OASIS program, just recently gave public comment at the Colorado State Board of Education meeting to discuss the importance of inclusion of the histories of LGBTQ plus and Black, Indigenous people of color in the Colorado Social Studies standards. There was a vote on whether or not those things should be omitted from 4th grade and below. And happy to report that the board decided to keep them in the standards. And it was really great to have youth advocating on that front. So these are just a few quick examples of some of our recent work, and it goes well beyond this. Next slide, please. So these are some of the potential policy priorities or areas that we know are going to be likely to come up this legislative session. So one of those is fentanyl legislation. And so the goal of this is reduce unintended consequences for harm reduction. Some of the legislation that passed had to do with some of the punishment or some of the ramifications of fentanyl use. So the CDM team is leading the efforts on that piece. We have heard from the Alliance, which is the heart lung cancer sort of association for the state of Colorado, that there is legislation likely coming out that would lower taxation on certain tobacco products. And so that's something that we are likely to work with them to oppose. The interesting thing about some of our legislative efforts are that some of our programs like tobacco or other entities that get funding from CDPHE are not allowed to actively advocate for policy at the state level. So we'll take that, I'll often take that on for my programs, or other leadership staff will do that advocacy or testimony. Health and environmental protection regulations are needed for after fire cleanup. I think this is one where we're going to be taking more of that proactive role and working to put together what that would look like. So that's in the environmental health division. Our programs, in particular in the family health division, are looking at how to help aid in the rollout of universal pre-K expansion. So looking at issues of quality of pre-K programs, workforce, affordability and access. So that's some of the work that's likely coming up this session. And then overall, as we know, public health funding, a lot of our work around COVID or emergency response was beefed up over the last couple of years. We hired a lot of staff. There's a lot of influx of funding coming to public health, which you all know. And we're facing some potential funding cliffs where a lot of that funding will end in 2023, if not at the end of 2022. So just working to track any legislation that has to do with additional funding along with our local partners. This is just a snapshot. A lot of our partners are still developing what their legislative priorities might be. So we don't necessarily know all of them. Any questions?
Do you foresee any legislation coming up this year with the around the natural medicines that recently passed with the psilocybin? Anything potentially that would arise from that?
That will be interesting to see what legislation and potential around regulation and what that whole process will look like, and what public health's role is in defining regulation. Similar to a lot of our work early on with the regulation of marijuana. I think we are anticipating some pieces around that.
Hey, Heather, this is
Sorry.
Lindy.
Oh, yeah.
Can I just ask a question? I don't see mental health coming through this list. Did I miss it, or is that not a priority that's been identified for this year? I'm just curious.
It is a priority. A lot of the legislation that was passed around mental health last legislative session, we're waiting to find out how a lot of that appropriation is happening. So there's a lot of funding initiatives passed last session that I think is going to help either set up specific funding for mental health or a grant process to become funded in some of the specific work. There will likely be new mental health legislation. I did hear that one Colorado was potentially looking at some legislation specifically around youth mental health and LGBTQ youth mental health. It wasn't listed here. This was just kind of a snapshot of things we knew for sure were, or had heard were more coming down the pike. But I do believe there will be mental health. That seems to be a major priority for the state.
Yeah, and honestly, this slide, the purpose of the slide was just to show that
Some examples of it.
it crosses every division in the agency. There isn't a division that doesn't have policy priorities that they would like to pursue. And this is not at all to be taken as a list. That specificity we'll get to more in January.
And Lexi,
Yeah,
I
thanks,
assume
Lexi.
that there will be an alignment to our strategic planning process as well, meaning those issues that we deem of highest priority for public health will be the potentially highest priority from a policy perspective as well. Is that a fair statement?
Yes, I think part of the purpose of recognizing the value of policy as a strategic priority is recognizing that it's a piece of how we create change that's missing from our arsenal of tools right now. So absolutely, part of the vision is that we are thinking of it in relation to our strategic plan.
But
Yeah,
sometimes,
And
I
then I
think
think
that would help us determine how much emphasis and resources and weight we're going to put behind certain issues, right? I would like to see, I mean, policy is clearly an enabler of strategy. I'd like to make sure that we're prioritizing, you know, relative to that, because there's of course going to be a million things. And I think we need to be ideally focused on our top priorities and putting our resources there.
I think that's part of the challenge currently with there not being a designated staff who does policy work. Right now, a lot of the policy we're involved with or responsive to is related to a programmatic area. So we have a program manager or staff who are engaged either at a local or a state level with any type of advocacy group. And so those tend to be the pieces that rise up. Because, you know, while Lane and I are doing our best to sort of monitor everything as it comes, we often rely on a staff who might hold content expertise or knowledge to bring those pieces forward. I do think if we had someone who this was their full-time job and they were tracking policy, it could be a more strategic, coordinated effort for sure. Yeah, next slide. Oh, sorry, go ahead, Lindy, if you were unmuting. So this just gives a little snapshot again, an idea of the type of work that we do around policy. So one of the ways the partnership with our Boulder County policy team works is we often help provide data or provide subject matter experts to testify or to write written testimony, talking points. We do coordinate activities to check in with either Board of Health, county commissioners, the county team, other partners to ensure that if we're testifying that we're coordinating like which public health entities might be testifying from which counties, who might have a stronger voice, which legislators need someone from their jurisdiction to testify, what might be most useful or most powerful. We do work with decision makers to advise them. I know last legislative session, I, with help from the Boulder County policy team, would email some of the legislators if we needed to provide talking points or information to help with. We work with our leadership when it feels like there might need to be a public health director voice at the table versus maybe Lane or myself or a programmatic staff, just to provide talking points for testimony. One of the, I think, more fun pieces for me is supporting the community partners who want to participate. So that can look like parents, families, end users, stakeholders, youth. I know the OASIS program in particular has supported youth throughout the 10 years that I've been in the community health division, and we're going for testifying or written testimony. And what we are hoping to do more of this year is to coordinate with you all on opportunities for engagement or areas where you might have particular interest on different policy issues that might arise. So right now we have Lane and myself as the policy leads for the agency. We are discussing building out a more formal work group to bring together staff who right now kind of engage informally or just through listserv where we forward information, but to have a more formal work group that meets. And we are hopeful that that will lead to a bit more of the proactive legislative work or policy work. I think, yeah.
Oh, sorry, Heather, I didn't mean to cut you off.
No, go ahead.
Do the other departments that would be, where a lot of these policies would impact them too, like HHS, community services. Do they have a policy person internally in those departments?
That's a great question. I'm not sure on that.
And so, and I bring that up thinking about, you know, is there a role for those three departments in particular to have a staff person that could help? Because again, a lot of the policies that you listed, Heather, as potential policies that you know are coming down the pipe, or other policies, I mean, some of them are very, very closely aligned with public health. A lot of them overlap with HHS and community services. And so thinking about how we might just coordinate department resources, not just from a cost perspective, but also from a lobbying or, you know, other ways that the departments might want to weigh in on those.
So my understanding, yeah, go ahead, Heather.
I was just gonna say, I do believe at the county level, some staff are more focused on sort of so I think Summer Laws in particular is more for human services related policies. So she's who usually reaches out to us, and community health. And I know she works closely with HHS and community services. I don't believe, and Lexi, maybe you know better, but I don't believe that any of the other departments within Boulder County have designated folks. But they may have people who allot some time to it. Not sure.
I think part of it is that structure of other departments being so much more integrated with the county,
right?
The county commissioners, because the policy team is embedded within the commissioner's office. Mm-hmm. And your point about the overlap is absolutely right. It's like, that's where we see this opportunity to like be really clear about who's taking this piece, right? Are y'all doing it? Are we doing it? Who's leading in these spaces? When they have situations where they need to pick and choose and prioritize too, this allows them to focus on, you know, policies that may be a little bit less public health specific, and gives us a chance to really lean into the public health work so that we don't fall through the cracks or whatever. So I think that that's part of the question is, you know, what we're really looking at, and that Lane's going to talk about in just a minute, is like, how do we test some processes over the next year and get a feel for what this work might look like and would require, so that we can make kind of some decisions based on piloting the work about, you know, what are the resources needed? Is it a half-time person? Is it a full-time person? Or is it something else that we haven't figured out yet? So I think that's exactly what we're kind of trying to figure out, is what is the structure and the resources that would make this work more effective.
And we may have some additional learnings from some of the local public health agencies that just recently created these types of positions. That might help us too, to figure out how that's going and what that balance is. I believe I'm kicking it over to you, Lane. Thanks.
Thank you. Yeah, and I think that Heather mentioned this. Our peers do have positions. I don't know if all of them do. I know Tri-County did before they dissolved, and I know Adams has already created that. I'm not sure if all the other individual counties have also followed suit. I know Jefferson County has policy position. So those are definitely things that other peer health departments in the metro area have seen as a need, and a need to fill. So we're just trying to think through what is the right process for us. And we definitely know that we are a lot more reliant on others because of our bandwidth to assist us in doing policy work. Back to that question on proactive work. It is going to be limited to the bandwidth within the programs where the policy is going to impact, of how much bandwidth they have and expertise they have. So those are some of our limiting factors right now. But some of the things that we're kind of envisioning is trying to create for you at least a timeline of some activities that we think are going to be important for us to do, as well as, you know, starting to feel out what would it look like if we had more internal capacity, if we had more staff dedication to doing this work. But similarly, things that we've done in the past, we do bring together, actually the commissioner's office brings together all the Boulder delegates and get to hear their priorities for the upcoming legislative session. They do a legislative breakfast. That's very insightful for us to have a good read, and with the recent election, just to get in touch with all the different folks that are going to be representing any part of Boulder County. And so that is an important kind of leaping off point for us to all be on the same page. And I think that's really been an important piece of why we've been so successful, is our commissioner staff are very coordinated with our delegates, and make sure that they're well informed and that they can then lead some legislation that is important for not just public health, but for the county as a whole. We have in the past, and we still would expect bringing to you some form of the county legislative priority agenda, which really aligns with ours. It has so much public health. We've kind of moved away from creating our own specific one, because the one that the county puts together is so comprehensive, and so many of the issues do overlap with our peers, and so we do care about things that even we may not lead. So again, bringing to you a legislative priorities for you to review and give support to, so that further enables our staff to go out and work on those areas. Looking at our policies, and again, the idea of a policy work group that Heather brought up, something that would also align with the interests that we've heard from the board, and how we can further coordinate with the board, really find ways to engage the board and even get you active where it makes sense. So any areas that you have expertise that you want to be more active in policy, this would give us more bandwidth to dig into those and really make sure we can get the right voices to the table. Heather talked about engaging the community. We've done that, but I think there's more out there that we can do, especially with more bandwidth. I think that voice of those impacted by issues carries a lot of weight at the legislature. So we are very data driven. We can share a lot of statistics, but those real world cases also are impactful. So really leveraging the real life stories in addition to just the data that we are able to generate. And then obviously the legislative session is kind of fast and furious. It kicks off this next year, January 9th, and runs until May, barring kind of delays or unforeseen circumstances. So that's a time period where we do need to be very well coordinated. And that's been a challenge for us in the past, is really making sure that we are in touch with who the right person internally is, who knows about issues, who could testify with very short turnaround. So that kind of need to be more streamlined and be more coordinated has been evident. I think we've done an okay job, but I know there's a lot of improvement that can be done during session. So that's really kind of a critical time to be organized. And then the idea of training others to testify, because there is some art and there's some nuances to testifying that make people uncomfortable. So really getting people through the nuances of how you testify in a committee and how they operate, I think is something that we could put some more bandwidth in if we had more resources. And again, it's something that needs to be done well in advance. You can't train someone minutes before they go testify. So again, those are those proactive steps that we would want to be doing on an ongoing basis in preparation for the legislative session. Then thinking of our efforts, as the board mentioned, we want these all to be connected and aligned. So as we do our community health profiles and we build out our strategic plan and set those priorities, there have to be clearly policy priorities connected to those. So that really helps us weigh in on, all right, where do we need to put our energy, especially given limited bandwidth, so that we can align all of those priorities into the energy we're going to put for potential policy changes. And looking for those opportunities. Really in the summer is when you need to be building those proactive efforts for the next legislative session. During the legislative session is pretty late to be trying to roll out something and finding sponsors and working through issues. So you're much more successful when you're much more proactive in planning things out really during that summertime and well in advance of the legislative session. And then I think there's really a need to look at how are we making sure whatever we do is is evaluated and connected. So again, thinking of piloting what we've talked about, some of these efforts, looking at building out a more comprehensive cycle of what activities we would do, what kind of resources are going to be needed, what really would it take to do these kind of things, and how can we be most effective. So that's, I think, where we're at kind of launching into this next year, is we'd like to start to put some more time and effort into building that out. And then again, we'd be back where we are sort of now at this time, is working with the partners and looking at what their priorities are and who's putting energy into which efforts, so that again, we're maximizing efforts and really leveraging the collective voice of public health. With that, I think next slide, we'd love to hear your thoughts on some of these ideas and what value you see here, and what are some of the things that you see that are rising to the surface.
I think I'd like to second Lindy's point about mental health and also expand that into behavioral health as well. You know, we have a vast lack of providers and facilities for mental and behavioral health. And I would like to personally, that is a priority of my own. I would like to see us act strongly in that area.
Yeah, and I would just add to that, I think Heather made the comment earlier that there's been a lot of investment made by the state, but I'd like to understand, you know, what has the impact been of some of those investments? What are we learning? And then where do we need to potentially invest differently, more, et cetera? But yeah, I appreciate that. And I also, Lane, I really appreciate you laying out kind of the sequence of events, right? So helping me understand the expectations of where we are today versus where we all will be for the next planning session. So thanks for laying that out. I really appreciate that.
Welcome. And I know the larger agenda that'll be coming to you, you will see mental health still outlined there. We were just given a snapshot of some of the things that we do know about, but it is, I mean, we saw it with the fire, you know, when the youth hospital was evacuated, they were evacuated to Colorado Springs. That's the closest available resource. So, you know, now families are going another hour and a half away during a tragedy with already dealing with adverse. So we know that the infrastructure is so woefully funded, and even though the infusement of the state money, there's going to be still major gaps. So it's not done for sure.
And I'll add to, through the work of the county level roadmap on mental and behavioral health, we are meeting regularly as a large group between community services, community justice, HHS, public health, to look at the different funding sources, what's coming out, who should apply in partnership, all of the different types of mental health legislation or appropriations that are coming out, just to make sure that we're doing that strategically.
And we'll definitely stay connected with Marcy Campbell, our good colleague that is not in BCPH, but still working on these issues for the county. So, but it is still a need.
Yeah, I mean, I think policy, like, hugely important, right, to BCPH's goals, to our strategies, to public health and equity. So I totally am supportive of putting resources towards tracking policy, reacting to policy, proactively putting policy out. I think I just want to be sure that we're sort of keeping an eye on all the coordinating that has to happen between all the various parties. So there's the commissioner's policy team, which, you know, they are tracking public health and other public health related issues, and they come to present to us. And they're working on this all the time, and they're down there with the Capitol. Then there's, as I mentioned, the HHS and the community services folks. And then there's the sustainability office, or Oscar or whatever, in the commissioner's office, right? That's doing, because I have an interest in air quality, which is also a public health issue. But then there's this whole department within the commissioner's office that took some public health people with them, and they're very active on the policy running. So I think that, like, what comes up for me again is, like, how do we support BCPH in having a strong policy presence without overwhelming whatever staff person this is gonna be with like all the different meetings you'd have to be in to coordinate between all the various parties within the county that are working on policy. So I think that's, for me, what comes up. I think you guys do an awesome job on all things. Public health and policy is a big piece of that. So, you know, how can the board support the work that you're doing, make sure that you have the time to do it, and then also be thoughtful and strategic about how we're working with all those other parties from Boulder County? We're all working on policy.
I think the two committee meetings that the county policy team hosts, so the Human Services Committee and now the new Climate and Environmental Policy Committee, that really helps with the alignment, who's doing what, who's advocating for what, where do they need public health to weigh in, where other departments taking leadership. It is a lot of meetings that Lane and I go to, but that really helps with coordination.
And your point is so well taken, Morgan, because I mean, as I was saying to someone the other day, public health is in everything. It's embedded in decisions all kinds of departments make all the time. And I think what we really want to get sharper on is where is our input and our leadership useful and valuable? Where can we step back so we're not duplicating work? And how do we not miss opportunities? Because, you know, as great as some of the interventions that we're able to do are, we also see lots of missed opportunities in this space where there just wasn't enough. There wasn't enough.
Yeah, and I think also, I mean, public health, when I think about, I mean, all you know, community services obviously has a lot of strong community partnerships too, but this whole idea of how do we leverage more directly impacted community voices also in the policy work, I think public health could take a real leadership role on. So it would be great to see that. And it sounds like there is not enough time right now designated from staff to be able to really attend to that. Is that?
That's the challenge.
Yeah, okay.
Yeah, when you get down to the rules and regulations piece, and you get down to rulemakings to revise or create those, that's where the bulk of that work is. Now, I would say that a policy analyst dedicated to policy is not going to be most effective in those, because you do have the former BCPH staff, Colin and Cindy, who understand the environmental, the air and climate side. But that work is just, there's so much, if you're really doing it right, to read, review, write on your own, that really takes subject matter expertise. I can't really speak much to higher level policies, state bills, state legislation, maybe even like county legislation. And so, but I do know that in certain times, that crush of work, it's not, sometimes it's sporadic. So the subject matter expert can be in and be out in a relatively short time, but then other times it's like the calendar is always full. So you're moving from one meaty topic to the next meaty regulation. And it's just like, if that's only part of your job, that's really difficult to stay on top of. And you pretty much have to triage, like, you know, these are our two high priority items and these other three things would be great. Hopefully somebody else can carry the water for those. But yeah, it's a struggle. I totally get the need to have that, you know, have a coordinating presence around policy, especially when it's not just in one subject area. So, but I do agree with Morgan is that, you know, I think hearing the county's priorities in January, I think will be helpful as a springboard for us to kind of think a little bit further about this in 23.
And I really appreciated the regular updates that we received this last year. Those were very helpful. But again, to echo what others have said, it was still so much. And it's going to be very hard to make an impact when we're still going through updates, you know, that are 50 pages long. And it's too much. There's not enough focus there for the department.
And, you know, how does the saying go? I didn't have enough time to write you a shorter letter. We don't have enough time to kind of pare it down and really create a package for you all that really helps you to digest, or our staff to really digest it effectively.
Yeah, but if the staff and the people that are spearheading it are going through all of this giant, this huge list, then we're probably losing some of our efficacy
Exactly.
by not focusing.
Yeah, I do think that would also be an advantage, is spending more time with the board to understand the things that are most important to you. So then we can, if we had more dedicated staff, whittle that down to get you the summaries on the things that are high priorities for the Board of Health. We actually have a public health intern, a PHAP from the CDC this year working in environmental health. And I just saw a summary of just some of the issues that are being heard by different city councils and municipal boards. And that was, I had never seen that before. So that was just amazing in just a few weeks, having somebody who's got a little bit of time devoted to the pulse of what's happening just in our community and things that are being discussed that potentially public health, if they're not already, should be connected with those municipalities to make sure they have our information, or if not, our voice being heard. So again, I think there's other things beyond just the state legislature that we just don't have enough time and bandwidth to be devoted to yet. We probably should be, because again, what's happening in our community, the municipalities have a lot of power to be setting policy to impact the health of communities.
And the school districts and all of those, yeah.
Yeah, absolutely.
Okay, well, thank you, Lane and Heather.
Thank you.
Forward to
Thank
seeing you in January.
So in the budget context, Lexi, this is gonna be part of your budget discussions, right? About prioritizing how you might carve out time for more work on this.
Yep. Great. And that should have, been on one of the bullet points on the fall is, what does this mean for our budget for 2024?
Yeah.
Okay, thank you again. Item 5 in the agenda, program spotlight, interagency fentanyl response.
So this is actually a great segue to the focus on MBH that we are trying to really reinforce. Last month's director's report provided a preview of the mental and behavioral health framework that we're using, that we believe will help us go deeper into primary prevention and better support the Boulder County community as part of a wider strategic plan. And as we mentioned, it's the first time that we've done a mental and behavioral health strategic plan with our county partners. So it's a really fabulous opportunity for public health to really kind of clarify, this is our role, this is what we do, that adds value that other folks don't. This presentation is intended to highlight a specific area of work that we're developing that responds to a high priority community need and aligns with the framework. Indira and team have been doing some really nice research and assessment of kind of what the needs are and where public health could really add value in the continuing urgency of responding to the fentanyl crisis. Indira in Georgia, are you with us?
I am.
Great. All right. So I'll do one more slide. If you can go forward, yep, Jordan. Good evening, Georgia. So this is just this is kind of a nice schematic that kind of shows the continuum in mental and behavioral health, all the way from promotion and prevention to treatment and maintenance. And that circle you see there is just kind of where public health's most important contribution is, that's kind of not duplicated by other departments. And so that tends to be where we feel like we can make the most difference. Also recognizing that when we are able to really focus on areas of prevention and harm reduction, we actually are lightening the workload demand for treatment providers and other highly trained, expensively trained training that takes a long time, professionals, which is part of our bottleneck right now in the response to the community's needs, is we don't have that workforce in place. And so the more that public health can kind of work in that space, the better we can kind of lighten that load as we get that workforce through the pipeline. So at this point, I will turn it over to you all.
Thank you, Lexi, and welcome, Board of Health. This is Indira. I'm sorry that I am participating by phone. I am actually at one of my children's many different activities, and so I'm shuttling in between. And I am joined here with Georgia Babatsakos, and Georgia is our harm reduction coordinator. I just want to give a shout out. You can go to the next slide, Jordan, please. I just want to give a shout out to Georgia. Georgia was hired during the middle of the pandemic. Right before the pandemic, I believe we came to this board in January of 2020, in which we said, gosh, harm reduction is just getting so big, and we want to make some organizational changes and create an actual harm reduction program, because prior to that, it had been embedded with Carol Hellwig as part of communicable disease control. And what has happened over the past, 10 years, the program has really been in place since 1989, but over the last 5 to 10 years, the number of participants in our works program has really quadrupled. It's more than that. It went from when I started in 2014, we had 200 participants. And as you'll see today, Georgia has almost 1,700 participants in our work program. So what we wanted to focus on today was just a quick overview of what's happening with fentanyl in particular, because the drug landscape is changing. So I'm just going to share some data on the fentanyl overdoses and what we're seeing in Colorado and Boulder County. And then George is going to share some of the data from the works program, so you can see how that has been changing over the past few years. And then this past January, we had an interdepartmental meeting and really got concerned about what we were seeing with fentanyl. And so we formed an interdepartmental fentanyl planning group with the county commissioner participates, and so does our district attorney and others from across the different agencies, including K through 12 school district partners. And really, it's that is just really functioning as a really smart group to identify strategies and to start working on implementing them. So we've got some exciting things to share there. And then George is also going to share just a bit about what is happening with funding, because there's just an explosion of money. This is a program where we had volunteers who had to run our program because we had no money to pay them. And now George has been able to successfully bring in a lot of great grants. So really just excited to share that with you. So if you can go to the next slide, I'm just going to kick off with some data. Next slide, please. So this graph represents the emergency department visits for fentanyl overdoses among Colorado residents. And 2019 is represented in purple, and 2020 is represented in green, and 2021 is represented in red. So since last year, this is Colorado data. The state has experienced 2.5 times the rate of fentanyl overdoses in Colorado, and a 10-fold increase since 2019. Next slide, please. This graph represents the emergency department visits for fentanyl overdoses among Boulder County residents for 2019, again in purple, 2020 in green, and 2021 in red. So in 2021, 38 residents presented to local emergency departments with a fentanyl overdose. And this is a 3-fold increase since 2020 and a 5-fold increase since 2019. Next slide. When we took a closer look at some of the opioid overdose data in Boulder County, next slide, please, we looked at all different types of opioids. So in this case, this includes things like heroin, Oxycontin, and other forms. So this includes fentanyl, right? So this is just kind of the larger picture. And when we looked at the county, we had a total of 98 total cases in 2021, so that red line. And the cumulative ED visits that we see here for opioid overdose were higher than what we saw in 2019 and 2020. So keep in mind that 98 cases, because what we are going to do is in the next slide, we break that down by different age groups. So a lot of people think that these types of opioid overdoses really impacts younger people. This is the 18 to 24-year-olds, and you can see from this that they represent 20 of those 98 cases. And believe it or not, the data for under 18 is completely suppressed because that means that we had fewer than 3 individuals presenting to the emergency department with an overdose. When you go to the next slide, you start to see where some of the numbers are increasing. In this one, this is the 25 to 29-year-olds. They're 21 of those cases, and again in red. And when you go to the next slide, the data really shows that the majority of what we're seeing with opioid overdoses is actually among this age group of 30 to 39-year-olds. So really kind of a middle-aged problem. That doesn't mean that we're not concerned about young people. We are definitely concerned about young people. But a lot of people think that opioids or fentanyl use it's a young people's exposure that might lead them to going to the hospital, but it's actually kind of that middle age, 30 to 39 years of age. And they represent the majority of overdoses in 2021 at almost 50%. So this is definitely a doubling of what we've observed in this age group from 2019. And when you go to the next slide, it will show that when we take a closer look at that 30 to 39-year-olds, that the majority, when you look at by gender identity, we see that that among those 30 to 39-year-old males in Boulder County present more of an opioid overdose compared to females. So definitely impacting males at almost twice the rate. Next slide, please. And then this bar graph is just looking at the visits for opioid overdose by race and ethnicity for 2019 to 2020 compared to the percent of the Boulder population. So what we can see here is that the majority of the cases for opioid overdoses presenting are typically white, non-Hispanics, but we are starting to see in that 20 to 20 age year range and 2021 to the right, we are starting to see an increase in our Hispanic of any race showing up at the emergency department at much higher rates. So this is definitely something that we keep track of. Georgia's also got some programming updates to share about what we're doing differently to address this. Next slide, please. Okay, and then this last one is just about data from the vital statistics. So next slide, please. This data is a lagging data. It just means that it takes a while for us to get the death records from the state health department. And so what we know is that in looking at this graph, it represents deaths from all poisonings in Colorado, and that drug poisonings, including alcohol, cocaine, and methamphetamines. But we know that deaths from drug poisonings are definitely trending up substantially every year since 2018. So you can see that 2021 is at the very top. We don't have the full set of data yet, but it's definitely higher than what we've seen in the past. Next slide, please. And so I want to turn it over to Georgia, and she's going to share with us about the WORKS program data.
Thank you, Indira. Can everybody hear me okay? Yep. So go ahead. Okay, so we can see on this graph how the number of unique clients that we get has increased dramatically since 2010. So over the last 20 years, we can see it's gone from 149 people to around 1,600 participants. So that is really a lot. And then the number of times they come into the actual service is a lot more than this. So they might come in 4 or 5 or 6 times per year. So and our numbers in 2022 are going to be around the same amount. So up until September of this year, we've seen around 1,300 unique participants. So we're on track for
seeing around the same amount of people. Next slide. So just in this year, we saw, so in 2022 up until September, we saw 1,321 unique individuals in 4,049 separate encounters. We provided around 327,000 sterile syringes, which is actually going down, and the number of glass pipes that we are distributing is increasing. So in the past, it's been more sterile syringes, but because people are smoking and snorting more, which actually reduces the risk of overdose and of HIV and hepatitis C transmission, we're actually seeing an increase in those other supplies, and we've just started tracking them a few months ago, so we'll be able to have more data on that next year. We distributed 1,191 naloxone kits through September of this year, and we conducted 72 HIV and 67 hepatitis C case tests, mostly in the jail. We've had still a lot of closures in the jail due to COVID, and we've had no positive HIV tests, even though we are working with testing a super high risk population in there. So it's mostly people who use drugs, but also our hepatitis C positivity rate is around 10%, where the national average for people who use and inject drugs is around 70%. So it demonstrates that this program really works. Next slide. So in terms of the strategies that we're looking at, first of all, with funding, our current funding is through 2 grants through Colorado Department of Public Health, one focusing on harm reduction and the other focusing on HIV prevention, but they fund very similar activities. We also have case management now funded. We've been receiving also some county funds for operating supplies, but that funding has not gone up in 7 years. So we're looking at advocating for more funding, because we definitely have had an increase in participants. We're looking at securing ongoing non-grant reliant funding through the opioid litigation funding, funding for our partners that we work closely with, such as BCAP, Mental Health Partners, the Jail and Recovery Cafe. And we also are looking at the new fentanyl bill to secure funding for the implementation of the plan that Indira is going to be talking about in more detail soon. The program strategies that we have been using, in addition to the syringe access and street outreach that we typically do, and the HIV testing, is to introduce case management and peer educators. That's been our more recent introduction. We've also recently hired a Latinx community educator, and we're going to be working with the consultant to really reach out more to the Native American community, because we actually, statistically, the people who come into our program represent higher than average in the population number of people from the Native American community. We are also spending a lot of time doing trainings on naloxone and overdose prevention and anti-stigma training to a lot to professionals, but also to parents and some other participants. And that's been hugely successful in supporting the understanding of what is harm reduction and having people sort of ready to administer naloxone, because once people really understand harm reduction, they're really on board with being prepared to, at any moment, at any time, to reverse an overdose. In terms of future strategies, we are expanding our anti-stigma campaign to move to the next level of really working with professionals on how to interact with people who use drugs. So targeting first responders, law enforcement, and medical personnel. And we're just nearly done with that training. That's a follow-up to the initial introduction training. We're also exploring and developing a drug checking program, because that's considered best practice in preventing drug overdoses, and particularly with the fentanyl being in a lot of different other drugs that people aren't expecting, those drug checking programs are essential for preventing overdose deaths. And then finally, we're looking at OD mapping, which is a sort of real-time program that we are just now having access to help make data-driven decisions about where to target prevention, harm reduction activities, and respond to where that happening in the past. Again, as Indira said, we have a lag. We had a lag of about a year of that data, but now not only do we have the data, but we have a map to see where things are concentrated. Next slide. I think back over to Indira.
So this past, I think it was the last December, the Substance Use Advisory Group was meeting and we started talking about fentanyl. And we have really some amazing relationships with the Sheriff's Office, the Drug Task Force, the District Attorney. Their office has been super supportive. And then through COVID, we've just built stronger and stronger relationships with a lot of key partners, both at CU and K through 12. And also, you know, just having run the Substance Use Advisory Group out of public health, it was born out of public health many years ago. We've built a lot of relationships within the treatment community as well. And so we got concerned about the fentanyl data that we were seeing. We were also hearing from community members that my son overdosed, or we would hear random community comments. At one point last fall, the Drug Task Force reached out to us and said, we've got some bad stuff in the community. We need to get this word out. So we have been working kind of proactively, but kind of limited in the way that we work and the limited in our information. And so we all hold these relationships with each other. But in January, we decided we really needed to formalize this. So we initiated an interdepartmental fentanyl planning and response group. And our group is really focused on preventing those opioid overdose deaths. We identified which priority populations we wanted to work with and really focusing on those who already use drugs, explore with drugs, or recreationally use drugs. And this also included parents of youth and young adults who might use drugs, where we knew that coming out of the pandemic, we were seeing a lot of mental health and substance use challenges. And so just making sure that parents knew what was happening, being more connected, just being able to take that harm reduction approach. And then, of course, you know, we have a strong connection with the unhoused. And so ensuring that the unhoused were not overdosing. And then those who are criminally justice involved, we have been offering, Georgia's been doing a remarkable job with one of her grants with the medically assisted therapy in the jail. And so just making sure that people who are criminally justice involved, whether they've gone through the system or not, that they know that they can get access to naloxone, get treatment if they need it, that they know that there are service providers out there in the community. And so this plan also recognizes that, you know, there's oppression of people of color, and that has been a long-standing challenge within the law enforcement community, who has been very open to recognizing that people of color have been disproportionately impacted. And so this plan also prioritizes our Black, Indigenous, and people of color, as well as individuals with language access issues. So these are kind of the tenets which this plan was built. Next slide. And then these are all the partners who are at the table. We have partners. Sometimes people just join us, and that's okay too. And we started meeting every month, and then we accomplished a lot in 5 months. And so we started moving to quarterly meetings. But these individuals on this slide right here, they take this very seriously, and they all attend the meeting. It's a high functioning meeting. It's only an hour, but we get a lot done. And I just want to give a shout out to the Sheriff's Office and the Drug Task Force, because they have really taken on some amazing work. Next slide, please. So one of the challenges that we have with public health using our data is that our data, our vital records data and our hospitalization data is really a lagging indicator. It's sometimes a year out. So it's not really good at being able to respond in the present. Another limitation is that CDC uses a resident's zip code to assign like a death. Well, the problem is that we could have a CU student who's actually a resident of California who dies in, you know, Boulder, but they're not counted within our numbers. So we're not actually capturing all the deaths in the community. And this came up with the district attorney's office, because they were like, hey, you know what? I invested I investigated this many cases. I'm just going to use a random number. I investigated 40 cases last year, but you're only counting 20 deaths. And so it doesn't really show the true burden on the system when we are using some of these traditional public health data sources. So we're really working closely with the Sheriff's Office to leverage a new system. It's called ODMAP. It's a system in which law enforcement and emergency medical services, so our local EMS providers, are able to enter information in real time, and the map actually updates in real time. So to look at if it is a save, how many naloxone was administered, if it wasn't administered, if there's a death. And so all of that data will be is being entered by law enforcement partners who, believe it or not, all law enforcement partners in Boulder County have committed to signing up and registering to commit to adding to this system. And the EMS and hospitals will be rolling out in 2023. So
Hey, Indira.
Yeah.
Sorry, this is Morgan. Sorry to interrupt you. To clarify your point about the data, so the 98 there's a to the ER.
Yes.
Are you saying that that is an accurate reflection or an undercount?
It's most likely an undercount because of the university presence. Yes.
Okay. And is BCH the only hospital that's participating with that data, or are you including the other Boulder County hospitals?
It includes that 98 includes all the Boulder County hospitals.
Great, thank you.
Yeah. So the OD map is really going to give us real-time abilities to make data-driven decisions. And so a few years ago, we developed an emergency response plan for drug overdoses because we knew that this was a challenge. And so Chris Campbell is actually going to be going back and meeting with a group in January and figuring out as a group, how are we going to use this new data to really help us figure out how to respond to emergencies. And that also includes some new strategies, such as, all the work Lane did with building the relationships with the business community. So we're looking at even like, how do we get into business community and let them know that there's tainted drugs out there so that people who work in those sectors are aware that they need to be really careful. And then the other strategy that we're looking at is training. Madeline Evanoff, who works in George's team, has been absolutely amazing working with Allison Bailey from Community Health Division under Heather Crate. And they have really done an amazing job of doing a train the trainer model in harm reduction and naloxone, and really just doing the prevention messaging, particularly for young people and their parents. So a lot of parents have signed up for get understanding. They want to know, what do we do to prevent these overdoses from happening? So a ton of work can still happen in this piece in the training space. We just heard today from Boulder Community Hospital that they have started initiating a training for their staff, and they're completely booked. When they opened it up, they completely booked out until the end of February. So we're looking at trainings also with George's new hire in looking at different bicultural approaches and making sure that the trainings are offered in Spanish. So lots of work happening in that area. And then one of the things that we realized as a group is that access to a naloxone is definitely an issue. We don't really want to focus on just the privilege of being able to have access to naloxone. So we are really focusing on how to figure out how to make it more accessible. So that OD mapping software is important because it also helps us figure out if we get some funding from the opioid legislation on to get some naloxone vending machines, where do we place them, right? If we're seeing overdoses in places like Lafayette, maybe we need to put a vending machine there. If there's no accessibility to naloxone up in the mountain communities, do we need to add one there? So we're using all this data to help us make decisions, but the decisions of where to put naloxone and how to get more community-based access is going to be driven by this substance use advisory group, which has been with public health for a long time. It got moved over to community services during the pandemic, but we're going to bring it back. And then the last piece is just around reducing stigma. There's a lot of stigma, and we really need to get out of this abstinence only kind of approach. particularly with youth who are really struggling, and move into that harm reduction approach. So those are the 4 big areas that we're working on. And next slide, I think we're done. And I'll stop talking and see if there's any questions for either Georgia or myself.
Do we have data on, oh, go ahead, Landry. You go ahead.
I was just gonna say, this is great. As you may know, I'm also boarded in addiction, and harm reduction is a passion of mine. I moved here from Massachusetts, and I feel like Colorado is about 10 years behind in terms of the fentanyl epidemic. You know, I think that we're ahead in meth and behind in fentanyl, and now it's catching up with Colorado as well. We really have limited access at the health centers, like surprisingly limited access to naloxone. And I think, I mean, I would be happy to talk offline with you too, but I really feel strongly that we need better access at the health center level. I mean, that's where a lot of people are coming for healthcare and treatment, particularly at the Alpine Clinic, but also at the clinic in Boulder as well as Lafayette. But I think the OD map is great, and please let me know what more I could do to support you, or if there's meetings I could come to just to learn more, so that I can inform my colleagues of the work you're doing too, so that we're making sure that our patients are engaging where they can.
That's great. I'm sure Georgia knows best about the bulk fund and how to access it. And Landry, if you want to come to a future, like our quarterly fentanyl meeting, I'm happy to add you too.
Yeah, that'd be great. I need like at least 3 or 4 weeks heads up. But yeah, that'd be great.
Landry, could you put your email in the chat? I mean, it's probably on some kind of list there, but we could reach out to you about the training of trainers, where we could train you to train other staff, and how to access the bulk fund.
That'd be great. I'm working on
We'll connect you. Don't put your email in the chat. We'll connect you.
Yeah, please do. Okay, I don't even know how to do that actually, as I'm trying. So if you want to direct clients to Clinica in Boulder, on Monday mornings, we're blocking part of my time from 10 to 12 for inductions. So please just like text me. I can almost always make it happen. So if somebody's ready and engaged and ready to start Suboxone, Monday mornings are where we're blocking time. And I'm using that time to train some of my colleagues who are Suboxone hesitant, I would say. And that's what we're doing right now. So Monday mornings would be great. I can almost always find a way if there's someone. I just think we should capture people when they're ready. And it's just hard.
Yeah. Thank you, Landry. I think Georgia will set up a meeting with Landry and talk through how we can make those stronger connections with Clinica, particularly with the jail too, just making sure that they know how to access in the system.
I have a good contact. You probably know her, Annabelle Perez, in the Longmont Police Department. I don't know if you work with her directly. Anyway, she helps with diversion from jail for
Okay.
So she's one of their case managers in Longmont. I worked with her when I was at Salute. I don't have a direct contact at Boulder.
Can I ask a question? I don't know if it was Georgia or Indira. You said that more people are smoking fentanyl now and shooting it. And I guess that's good from a overdose or a death perspective, right? It sounds like it's better, but what about like secondary exposure for like first responder type? Do you get those questions? Or is this all too new?
We absolutely get those questions, and we actually trained federal law enforcement officers last year because they didn't have any training at the federal level. We basically, the secondary exposure yeah, unless they're ingesting it or directly sort of snorting it into their nose, that exposure is not possible. And because of, you know, the program that we operate, if that were so, that we would all be exposed, but we're not. So there's a myth about that. And we actually have a specialist who from the Colorado Consortium who'll be speaking to that. I think it's this Wednesday, if anyone's interested in coming. So that is a myth, and that's not substantiated. So we definitely try to do that education around that with people.
Georgia, you took the words right out of my mouth. I was going to jump in. It's in the news and everyone's afraid that they could touch it, and all of those cases that have been in the news and in the ERs and all of that has really pretty much been disproven, Greg. It's all based.
And I have an article that I can forward as well.
Yeah, unless someone's directly inhaling it with the intent to use. But coming into contact with it as law enforcement, I mean, they should wear gloves and use basic protection precautions, but it won't happen.
Okay, thank you very much.
Can I ask a question about, do we know where naloxone kits that BCPH or anybody else has distributed have worked? I mean, I figured that's a harder thing to track, but do we know where we've been effective in providing those kits to folks?
Yeah, so one of the beauties of this OD map is it's going to track all of that. And I'll give you an example because I sit on the City of Boulder's community engagement panel with Brooke, and they saved 19 lives last year administering naloxone, just the City of Boulder PD. And that doesn't include City of Longmont or Louisville or Erie, but there are a lot of law enforcement who get to a scene before EMS gets there. And so they're often able to report how many lives that they've saved. And it's very powerful for law enforcement because they know, they can physically see, you know, the reversal in real time. And I don't know, Georgia, about the WORKS program. Are you collecting numbers on participants who report reversals?
Absolutely, and that's a big gap because oftentimes participants will report to us and they have not reported it to any first responders. So we get between 10 and 15 people a month that come in and say that they've used naloxone to, you know, reverse an overdose. So we definitely get that feedback, and definitely that's one of the issues with the data is that there are people, participants in the community who are not reporting that to law enforcement. So we're hoping with the OD map information that we get that side of the law enforcement side of stuff. And it is difficult to have a really an accurate picture, but definitely we are on both sides. We're seeing reports of reversals.
That's great. I mean, I feel like that's a story that we need to tell more broadly. I mean, not just to help encourage people to take naloxone kits, but just in the media coverage, you know, we had some not great coverage last year or in the last year for overdose deaths in Boulder County, but just to be able to tell the story about all the positive intervention work that's being done too.
I guess along those same lines, because Indira had asked about if you're tracking people who are noting a reversal that are of those unique clients to the works. In addition to an OD map, are you also tracking demographics of the unique clients? Like we see this number that are located in this area where there could likely be an overlap with a higher rate of overdose. I guess how much demographic information do you track for the unique clients in the works?
We definitely track that information. What we don't track is like where the overdose took place. And so often that's not where they're living. So because people do move around a lot. But we definitely have demographic information. And we actually had a student recently analyze some of that information. So what we saw, not so much with demographics, but we saw that the longer people are in our program, the lower the chance of them overdosing. So that you can say like in the first year reported, because often people overdose and survive, as we know. So the longer they're in the program, the less chance there is of them reporting an overdose. But in terms of demographics specifically around that, we don't really have an update about where the overdose occurs. Don't collect that level. But we could say something like, if we did an analysis, we probably could say, so the question is, did you use the naloxone to reverse an overdose? It doesn't necessarily mean of themselves. So it's not a research study, let's put it that way. And we don't, yeah.
And Georgia, a few years ago, the state, as the harm reduction program started expanding, Carol used to collect the information for each, unique user. So, and then the state came in and said, let's use REDCap. So there is this whole REDCap system in which when you come in as a works participant, each year you actually have to kind of re-enroll, and you have your own unique initials, and you have your own kind of unique information that you used to be able to access the system. But you have to fill out a demographic form. And so we do have all of that data, if that's what you're suggesting, because we can look at age, race, ethnicity. And we have to be careful with people when they overdose of not asking for an address, because people can get very kind of paranoid about, am I going to have like a law enforcement officer show up at my door? Even in the OD map system, where, that system is not going to be made publicly available. That system is just going to be for specific users to be able to use it to make data-driven decisions. But that's not going to be open to the public, because it has some of that unique metadata that's assigned to each one of those GIS located spots. I hope that helps.
Yeah. And I do have to say, I mean, this is not a comment on the works program itself, but this, having went from 149 unique clients to 1,658, it's depressing. And I think that also plays into, not saying abstinence only, but into a real need for more behavioral health access. Again, not a reflection on the program, but it's a depressing jump in the number.
Yes, and that is one of the reasons why we did an emergency ask, I think in 2016. Jeff and I did an emergency ask to the Board of County Commissioners, because we were running out of money. Like, we had run out of money to buy supplies because the numbers had just been jumping and jumping every year. And then the other thing is, that's when we initiated the Substance Use Advisory Group. So we're really actually very lucky, because we were able to see the numbers in the works program go up so rapidly. And then we have been working on these kind of interagency relationships. The Substance Use Advisory Group is really connecting to community and getting people into recovery. So I think we're doing some amazing work. And this challenge that we face, like you're saying, it is depressing, and it's national. It's not just happening here. I just feel like within the community, though, we've had a lot of tremendous support to be able to address it.
What we're seeing in Boulder County in terms of the increases is not any different than other communities. And I think the fact that the Works program does also connect people with counseling and support services is an important aspect of that work.
Do you have the percent that you have referred into treatment and counseling?
And we could probably bring that back to you.
Yeah.
Okay, Georgia. Oh, no, go ahead, finish your thought.
I was just going to say, there's a statistic that is used, that we use in our presentations, that people in syringe access programs are 5 times more likely to go into treatment. So by being there for them, they might come in for 2 years and then suddenly say, I'm just tired, I'm ready for, to get treatment. So that's why these programs are so effective. We reach the people, we're there for them when they're ready, versus somebody who's just, not connected and doesn't have that resource. So it definitely is an important connection for people when they're ready. We never push treatment on people, but we, in response to these sorts of demands, we have added a case manager and been funded for a case manager to do that work. So we have a lot more time to spend with people to make those connections, so that's been super helpful.
Okay, Georgia, Indira,
Oh, sorry. I was just gonna say, we definitely should get together because we have a behavioral health counselor and a case manager at Clinica. So if they're in Boulder and Peoples be a good location, you should have their numbers for treatment.
That would be great. And we definitely, so you're at the People's Clinic, is that where you are?
I'm at the People's Clinic.
So we did meet with someone, Madeline and I met with someone last year there, and it's a person who's over substance use for all of the clinics. I can't remember the person's name, but
Is
we
it
met with them.
Emily Milano or Amber Inova?
I can't remember. It's been probably about a year since we met with them, but we did connect with them, like within the last year. So it'd be good for all of us to get together.
I think so. And yeah, there's there's a behavioral health coordinator, but there's also, for people in Lafayette, there's sites there. And I still have enough connections at Salud as well that, we could all, just so that you have a good solid list of places when someone's ready.
okay, folks, we have to move on in our agenda, but I really appreciate the information, Indira and Georgia. Look forward to hearing from you in the future. Good luck on your funding with the various settlements. And thank you.
Thank you. Thanks so much.
Thanks for having me.
Thank you.
All right, so we've got items 6 and 7, which are director's report and all the new business. You guys okay if we skip those this month so we can go to executive session?
If you have questions, you can email me.
Okay. So,
Hey,
item
Greg.
eight on the-
Hey,
Yes.
Greg, I'm so sorry. I know you're trying to move things along. I do have a couple of questions that I wanted to ask, if that's okay.
Can I just ask a quick question then? I didn't know that we were having an executive session after this. I have family and they're waiting on me, so I have to leave at 7:30. Do we?
You don't need to be here.
Okay.
It's not a quorum.
Okay.
So we can go ahead with your questions, Lindy, and then we'll just go into executive session when we're done with that.
Okay, I'll make it really quick. And Lexi, thank you for those reports. They were fabulous. Fantastic work. Fascinating and really helpful to hear. So I think 2 questions. The first is, this is mentioned in the executive report, but when is the CHE and the PHIP being administered again? If you can just remind me of that, the timing.
So there's 2 selection processes. One is the community profile, which is the broad look at a wide variety of community needs. That should be completed by the end of the calendar year. And the planning for the community health assessment, which is this more specific focus on mental and behavioral health that will inform the planning for our public health improvement plan focused on mental and behavioral health, will be a little bit longer because we'll use a community engaged process. So we expect that to, I think it's March to April, to be able to include those conversations with community about priorities and how to move forward in the planning process.
Okay, thanks for that. The other unrelated questions is I noticed that there were several key positions that are getting filled, and thank you for those updates, including the mental behavior health coordinator, emergency management planner, et cetera. I think what I'd like to understand, Lexi, is it possible to get a list right now of your key positions that are still unfilled? I just want to make sure that the Board of Health is clear on where we're still gapped potentially.
Right.
And
so that's actually in the director's report. If you look at the roadmap update on one of the slides, it provides a list of the positions that have been recently filled and the positions we're working on filling, the key positions.
Okay, I must have missed that somewhere. I will look for that. Thank you.
I will tell you exactly. Yeah.
Oh, got it. Okay, perfect. Thank you.
You bet.
Okay. All right, so item 8 on the agenda is we're going to go into executive session pursuant to Colorado Revised Statutes 24-6-4024F discuss the Boulder County Public Health Interim Executive Director salary and performance evaluation process. So, with that, thank you, everybody, for your attendance. And we will go into executive session. I think Landry and Lindy, you'll have to go to the different link.
Okay.
So we'll see you all next month.
And President Thomas, if I could chime in real quick.
Sure.
The statute does require public health to offer to make the personnel exec session public. If interim director Nolan would like it to be. So Lexi, would you like this discussion to be part of the open meeting and we can stay on, or are you comfortable with it being an exec session?
I'm comfortable with it being an executive session.
Perfect. All right. Thank you all.
Okay, thanks.
Thank you.